Good evening, everyone, and welcome once more to the Vascular webinar series organized by the Vascular Society, Aspire Digital Program, together with BSET Education. And tonight's title of the webinar is Management of Symptomatic and Asymptomatic Carotid Disease. And it really gives me great pleasure to welcome our speaker who really needs no introduction, Professor Ross Naylor, who's the Professor of Vascular Surgery at the University of Leicester, and more importantly, past President of our Society, and past Chief Editor of the European Journal of Vascular and Endovascular Surgery. And many of you who are familiar with carotid disease will also know that Ross is the chief author of the 2017 ESVS Carotid Guidelines. And I'm very pleased to let you know that he will be back once more to oversee the 2022 edition of the ESVS Guidelines. And so welcome, Ross.
Thank you very much.
And our panelists tonight, we welcome Richard Ubulia, who is consultant vascular surgeon at the Gloucester Hospitals Group NHS Foundation Trust. Richard is also the PI, the co-PI for the ACST trials, and is currently research fellow at the Clinical Trial Services Unit at Oxford University. So welcome, Richard, to the panel.
Thank you, Patrick.
And last but not least, Domenico Valenti, who is a consultant vascular surgeon at King's College Hospital in London. And Domenico has a large volume, a high quality carotid practice for both symptomatic and asymptomatic carotid disease. And the last time I looked up Domenico on the NVR, on the VSQIP website, I believe he's got the second largest carotid practice in the UK in terms of volume. I don't know who the number one surgeon is, but please enlighten me. So welcome, Domenico.
Thank you very much. I would like to know the other guy as well, Patrick.
Right. And without further ado, I'm going to pass the time to Professor Naylor. Ross, take it away.
Thank you very much. I thought long and hard about how to give this presentation tonight, and I thought of a novel way of dealing with it. We're going to deal with the same patient. In one scenario, he's going to be symptomatic. In the other scenario, he's going to be asymptomatic. And I'm going to take you through how you plan the management of these patients, what the evidence base is, and how to proceed. So we have a 79-year-old male who's got a history of hypertension, diabetes, and smoking. He's previously been on dipyridamole and ramipril, and he's had 3 episodes of right arm weakness and dysphasia lasting about 30 minutes over the preceding 6 days. He's had some imaging done by the time he's referred to you. He's got a 70% left internal carotid artery stenosis, which is quite long. And he's got an occluded right internal carotid artery. And there's a small left recent MCA territory infarct on CT scanning. Now, the way I teach my colleagues and trainees how to approach this is in a standardized 5 questions. First of all, was the event that's being presented a stroke or TIA? If yes, which vascular territory? What risk factors need to be addressed? Is the patient on optimal medical therapy? And should we be considering a carotid intervention? So first of all, was this a stroke or a TIA? Well, yes, there's pretty good clear history of this. The next question is which vascular territory? Now, carotid territory symptoms are classically hemisensory or hemimotor loss, higher cortical dysfunction, which for example is expressive dysphasia in the dominant hemisphere or visual spatial neglect in the non-dominant hemisphere, and monocular or unilateral visual loss. Vertebral symptoms include unilateral or bilateral motor and sensory loss, bilateral visual impairment, dysarthria, and then either ataxia, vertigo, or dizziness, provided these are not isolated. If you have isolated dizziness or isolated vertigo, this is not a TIA and it is not a vertebral basilar symptom. So when we look at our patient, he has heavy motor loss affecting his arm and he's got expressive dysphasia. So he's had several left carotid territory TIAs. What risk factors do we need to address? Well, we need to address the hypertension, his lifestyle and diabetes. And is he on optimal medical therapy? Well, most certainly not. Now, in terms of lifestyle, really these apply to both symptomatic and asymptomatic patients. And you can see there that in meta-analyses, smoking increases the risk of late ischemic stroke significantly, while moderate or high physical activity reduces stroke risk by 25%, and obesity significantly increases the risk of stroke. So guidance and advice on that is necessary. Now, what about best medical therapy in this patient? Well, according to our guidelines, we would normally start this patient on 75 milligrams clopidogrel for preventing stroke, MI, and other cardiovascular events, with aspirin and dipyridamole as the second line treatment. And you'll see a lot of asterisks there because I'm going to come back to this in a minute. There is no role for higher dose aspirin. The ACES trial in 1999 showed that high dose aspirin did not confer any benefit to the patient over low dose. Meta-analyses have shown that statin therapy reduces perioperative death after surgery, and it reduces perioperative death and stroke after stenting. It also reduces late stroke and MI, and the important message is you should not stop statins during the perioperative period, as there's an increased risk of rebound myocardial infarction. We have to control blood pressure with a normal target of 140/90, but if you have a diabetic patient, the threshold should be reduced to about 130/80. Now, I mentioned to you that there's something new happening about antiplatelet therapy. And that is because there have been a number of very large randomized trials which have now been meta-analyzed, and there's about 16,000 patients in this group. And what they showed was that if you start dual antiplatelet therapy, that's aspirin and clopidogrel, within 24 hours of symptom onset, there are significant reductions at 90 days in non-fatal stroke, non-fatal ischemic stroke, moderate to severe functional disability, and poor quality of life. And the British Medical Journal group have put out a clinical practice guideline strongly recommending dual antiplatelet therapy within 24 hours of symptom onset, but it only needs to continue for 21 days if you're treating them medically, and thereafter they stay on clopidogrel. And importantly, although there was a very small but significant increased risk of significant bleeding, the lay members of this group concluded that a non-fatal stroke was 2 to 3 times more worse than a serious GI bleed. Now, this is an algorithm for prescribing dual antiplatelet therapy in patients on the left who have a subsurgical stenosis, in the middle, a significant stenosis but in whom you're not considering a carotid intervention, and then on the right, patients with a significant stenosis who are being considered for expedited surgery. I'm not going to go through all this. You can see this algorithm in the June issue of the European Journal. And when we come to review best medical therapy in the next set of guidelines, I think we will probably be recommending that patients start on dual antiplatelet therapy and that it continue through the perioperative period. Finally, now we've addressed the risk factors and the optimal medical therapy, should we be considering a carotid intervention? Well, our imaging has shown a small left carotid MCA territory infarction. We've got a 70% stenosis with an occluded right internal carotid. But before we consider the patient for surgery, we either have to corroborate the first duplex with another duplex scan by a different technologist, or to do CTA or MRA. And this is especially important in patients who have 50 to 69% stenosis. This is the evidence base that advises on which patients might benefit from a carotid intervention. And this is pooled data, 5,000 patients who were randomized within ECST, NACET, and the Veterans Affairs studies back in the late 80s. And what you can see here is that our patient falls into this category. He's a 70 to 99% stenosis with a 5-year risk of stroke surgically of 17%, 33% on medical therapy. So there's an absolute risk reduction of 15.6, which is huge. And it equates to a relative risk reduction of 48%. But even with those impressive data, look on the right-hand side. Only 156 strokes will be prevented at 5 years by doing 1,000 endarterectomies, i.e. 850 or so will undergo an ultimately unnecessary intervention because they were never destined to suffer a stroke. So should a carotid intervention be considered? In my eyes, yes. Patrick, over to you.
I'm going to pause and ask Richard and Domenico their thoughts on what Ross has shared. Any differences to what you might do for this patient? Richard?
Ross, great overview. I agree with almost everything that you said. And one obvious concern about intensification of antithrombotic therapy in the peri-procedural period is the increased risk or possible increased risk of hemorrhagic complications, both due to surgery and also hemorrhagic stroke. I know you've written previously about your good surgical outcomes operating on people in Leicestershire who are on dual antiplatelet therapy, clopidogrel and aspirin. But is there any more sort of randomized evidence or larger case series suggesting that this approach is safe?
Well, first of all, to that, Richard, I would say we now have pretty good evidence that patients who've suffered an event should be on dual antiplatelet therapy. And what we have to remember is these patients, while they're waiting for their surgery, that's actually the highest risk period for having their recurrent stroke, i.e. before you've got them into the operating theatre. I've been using dual antiplatelet therapy now for 10 years. And I know that it's increasingly being used around the rest of the world now as our anxieties have been allayed, provided you take time to get good hemostasis, and most importantly, that you have guidelines for managing post-end arterectomy hypertension. I don't believe there's any evidence of significant excess bleeding, and this was backed up by the VQI in America and by an audit that we did in our service as well. So everyone has this innate intuitive fear of dual antiplatelet therapy, but I think it's overrated.
Yeah, we use dual antiplatelet therapy at Frimley, and we've not had any significant problems with bleeding. What about Domenico? What's your experience?
I completely agree with Ross. I mean, I've been using dual therapy for the last 14 years, and the only brain hemorrhage that I had in my series was postoperative hyperperfusion rather than a dual antiplatelet treatment. The question I would like to ask you, Ross, is if you see a patient with symptomatic significant carotid artery stenosis and the patient is only on aspirin, you start with 75 milligram of clopidogrel, or the patient needs a loading dose like we do for carotid artery stenting?
Sure. When we did the randomized trials back in about 2004, we did a whole series of tests on loading doses before we came up. And at that time, we only used to give 1 tablet of clopidogrel the night before surgery in addition to aspirin. And that will reduce aggregation to ADP by 40%. It's a potent drug. And so we wouldn't give them a loading dose of 300. What we do in our practice now is that our patients are seen in the TIA clinic. We've got a rapid access clinic that runs every day of the year. And once we've excluded hemorrhage on the CT or MRI and they've got a significant stenosis, the stroke physicians physically start the patients on dual antiplatelet therapy in the clinic. So they come to us already having started, and then we will get them into theatre as fast as we can. I would stress once again, it is so vitally important to have written guidance for how you treat post-end arterectomy hypertension. The other thing as well is if you get prolonged bleeding, say after you've restored flow and you've got the leaking through the suture holes in your patch, my colleagues used to blame me for the dual antiplatelet therapy, but when we did TEG testing, it was actually a heparin effect. So the chances are it's not a antiplatelet problem, it's a heparin sensitivity problem.
Mm-hmm. Maybe a few quick questions from the audience. Thank you for submitting your questions. Maybe I'll ask Ross these questions. Someone's asked an interesting question. Mohammed Hassan Abdulati asking, is there any role for low dose DOACs and NOACs in best medical therapy at all?
Well, I presume that's coming out of the COMPASS trial. The problem there is that they're not specific enough for patients who've got symptomatic carotid disease and for what to do in the hyperacute period. it's been difficult enough speculating with the carotid patients with the dual antiplatelet therapy because nobody's done any large randomized trials in these people. So that no, I have no experience of using the NOACs or DOACs in this situation. I'm just pushing hard enough now to get the dual antiplatelet therapy. I'm not sure. I mean, we will certainly consider it when we come to the guideline group, but I'm not sure that I would. But that's just my personal opinion.
Richard, you want to add?
Well, I was quite struck in Compass by the huge effect it had on stroke. So I completely agree with Ross that it's an evidence-free zone about the peri-procedural management of patients using rivaroxaban or similar agents. But I do think that for the long-term stroke prevention, rivaroxaban plus aspirin, low-dose rivaroxaban plus aspirin in a dual fashion might well be an interesting thing to explore.
No, I would agree. I mean, and we will certainly, Dominic McCabe's our antiplatelet expert, and we will certainly be considering that because that was a question put to the writing group as we started to meet up as being something that we need to address.
Yep. So interesting question, thank you, but the evidence is yet to be established. And Dana Skorova has asked, and Ross, perhaps you can answer her, why do diabetic patients have to aim for a lower BP level?
Because they're much more sensitive to having adverse cardiovascular outcomes. It's nothing to do with the carotid stenosis per se, it's because they are more prone to having adverse cardiovascular outcomes, and therefore you need to be more strict in their blood pressure control.
Sure, I think we should carry on perhaps, shall we, Ross? Let's carry on.
Okay, so, hey doc, I don't want to have an operation or I'm not keen. Come on, am I really likely to suffer a stroke? Now, I do that with some levity, but I teach my trainees to be able to use the evidence base that we have to work out whether the patient sitting in front of them is really very high risk for having a stroke or perhaps lower risk. And I'm going to go through some of the features that I consider. My friends Henrik Sillison and Torben Schroeder and I published a review about 5 years ago based on all the randomized trials. And we published this table, which was a list of clinical and imaging features associated with a higher risk of stroke on medical therapy. And let's look at our patient. How many of these does he have? Well, he's got 5. He's 79. So if you look at the top left, he has an absolute risk reduction of 19% in late stroke, compared with only 5% if he was under 65. He's got very recent symptoms. That puts him in the highest risk category. He's male. That puts him in a high risk category. And he's had hemispheric versus ocular symptoms. Now, the most important thing is that he has a contralateral occlusion. Contralateral occlusion is one of the single biggest predictors of increased risk of stroke in patients who present with a symptomatic stenosis. And the most important of these, I think one of the most important findings of the last 20 years with regard to subgroup analyses is the importance of intervening early. And this is a meta-analysis of the ECST, NASIT, and VA data presented in a slightly different way, and it's the number of strokes prevented per 1,000 operations at 5 years, depending on whether you have a severe stenosis or a moderate, and then stratified for delay to performing the endarterectomy. And you can see that the maximum benefit is conferred if you operate within the 2-week period. And as you increase the delays, the benefits start to disappear. And actually with the moderate stenosis, for the overall group, the benefit possibly disappears at 4 weeks. But this slide is possibly even more important. This is the stroke risk after you've had a TIA and you've been diagnosed with a 50 to 99% stenosis, and then it looks at what the natural history risk of stroke is over the next 2 weeks. Now, on the top line is the 5-year risk of stroke on medical therapy in the randomized trials, and that was 21%. Now look below that at the early stroke rates, and some of them are approaching 20-25% within 7 to 14 days. And this tells you 2 things. Firstly, the highest risk period for suffering a stroke after onset of symptoms is the first 7 to 14 days. But more importantly, these patients were never randomized with an ECST and NASIT. they had their index TIA, they then had their stroke long before they ever had a chance to come through the system. And that's because in my generation, when these trials were done, the pathways for TIA and minor stroke patients was really poor. And the reason why it's so high risk is summarized in these two carotid images. The prevalence of fresh thrombus overlying disrupted plaques is so high when you intervene in the first few days after onset of symptoms. And that's why the European Society recommended that when revascularization is considered appropriate in symptomatic patients, it's recommended that this be performed as soon as possible and preferably within 14 days of symptom onset. We also advised that within this 14-day period, patients should probably undergo carotid endarterectomy rather than carotid artery stenting. Now, why is that? What evidence is there to justify a preferential approach towards surgery rather than stenting? Well, let's just look at the overall 30-day risks of stenting versus surgery. And this is an overview of the primary and secondary analyses from the 20 randomized controlled trials that my group published just recently. And this slide shows you the 30-day outcomes in 4 trials that randomized more than 500 patients. And there's almost 5,000 patients here. And the red boxes, there's a significant difference, and blue boxes, no significant difference. And what you can see is that stenting was associated with significantly higher rates of stroke at 30 days, death and stroke, and death, stroke, and MI. And this is for all the time periods. I want to follow that up by showing this slide, because this is one of the most important slides in the collection tonight. And this is, once you've got past the 30-day period, what is the risk of having a late stroke if you're treated with stenting or surgery? And this is a meta-analysis of the 4 randomized trials with symptomatic patients. There's about 5,000 here. And at 5 years, the risk of ipsilateral stroke is only 3% for both groups. And at 9 years, it's only about 4%. So this is telling us several things. One, following a successful carotid intervention, the risk of stroke is very small. And secondly, stenting is durable and equal to surgery as long as you exclude the 30-day risk. And that's why it comes down in this editorial that Gerrit de Borst and I published back in 2015. In the end, it all comes down to the beginning. The destiny of the patient is determined by what happens in the first 30 days. So when you're looking at our patient who presented, we need to look at those factors that mean that surgery might carry an increased risk or that stenting might carry an increased risk. And then we determine which is the preferable intervention. So the factors associated with an increased risk of death or stroke in our, if we did CAS, are in being 79 years old, multiple recent symptoms, and adverse plaque morphology. And factors associated with increased risk after carotid endarterectomy is a contralateral occlusion. And I'm going to show you the evidence why I've boxed these as I have. First of all, this is meta-analysis of the 3 European randomized trials comparing stenting with surgery, stratified for whether interventions were done within 0 to 7 days and 8 to 14 days. And you can see that there is a very much higher rates of death and stroke if stenting is performed in this time period compared to surgery. Because surgery's been looking at the stratification of delays to symptoms for some time now, we've got large national registry data. And we've got the Swedish here, the UK, and the German. And the Swedish study showed that if you operated within 48 hours, there was a very high death and stroke rate. And this statistic has dominated thinking in guidelines at present. But actually, the UK and the German registries, which were way bigger, did not find this very high complication rate. The reality is, however, it's very difficult to get somebody through the system from having developed their symptoms to having an operation within 48 hours. So the debate is probably moot. The most important thing is that the surgeons have demonstrated that they can perform endarterectomy within 7 or 14 days with commendably low risks, i.e. we're not putting the patient at excess risk of complications through intervening early. Now, I'm not meaning to disregard stenting or like that. there have been some major advances. Here are systems where you've got a combined stent, proximal balloon and distal filter protection device, mesh-covered stents, and the TCAR system. The TCAR system is a very innovative, novel idea for performing carotid stenting involving direct access to the common carotid artery, so you don't have to negotiate the aortic arch, which is thought to be a reason for a lot of procedural embolic strokes. And a number of registries suggest that outcomes are very similar to surgery and superior to transfemoral CAS. But the reality is there are no published data for using TCAR within 14 days of symptom onset. So it's very difficult to be able to predict how this technique will work in patients undergoing stenting within 48 hours or 5 days or 7 days until we have better quality data in this situation. Back to you, Patrick.
Thanks, Ross, for that summary. Really great set of slides looking at CAS versus carotid endarterectomy. I just want to ask, perhaps Domenico, in your practice in South London, how important does CAS play for symptomatic patients? Is there a role for it, do you think?
Very minimal, Patrick. We are still a strong believer of the old-fashioned carotid endarterectomy. Obviously, the worry is not is the future with the intracerebral thrombectomy, where the interventional radiologists, when they are doing the MCA thrombectomy, they see a significant carotid artery stenosis and will decide to angioplasty and stent the carotid lesion. And I've seen few already in London being treated like this, and it's a bit of a worry.
Yeah. Richard, is CAS a feature in the Gloucestershire Oxford groups? I mean, do they choose patients for it, and how do they select?
No, so for symptomatic patients, no, unless there are specific reasons why surgery is considered extremely high risk. For example, the irradiated neck or the redo carotid stenosis, which has caused a recent symptom. Those are patients whom we may consider stenting. But I think, more generally, the British are quite a conservative bunch. We're also quite unimpressed by the randomized evidence, which consistently for symptomatic patients shows that the procedural risks in terms of stroke are much higher for stenting than for surgery. But I agree with Ross that you need that after a successful, once you've done a successful stent or successful surgeries for symptomatic patients, both procedures appear to be equally durable in the long term. So the challenge and the bar, as it were, for stenting enthusiasts is to reduce their peri-procedural stroke risk. And avoiding the aortic arch will reduce some of those. Better stent design with the micro mesh covered stent will prevent a prolapse of atheroma and distal embolization of that. And also probably better experience and better case selection might also help reduce your peri-procedural risks for stenting. So I think the door is not open for stenting for symptomatic patients, but it's not slammed and locked shut either, I think.
Patrick, can I just come back on something Domenico said?
Yeah.
The issue of the tandem lesions with the intracranial occlusions and the proximal occlusions or stenoses, this is a highly controversial area, and there's actually no consensus in the world literature. There are the hawks that say you should do it, and there are the doves who say the risks are not justified. But what I would say is there's considerable logic. So that if you do an intracranial mechanical thrombectomy and you've not managed to restore inline flow from the proximal carotid, and there's not enough collateral flow via the circle of Willis from the opposite carotid or the vertebrals, then you are really duty bound to try and open up the proximal inflow, because otherwise you will have a bad outcome from the mechanical thrombectomy. So that is a situation where you do need it. It does seem justified to do a tandem approach, but there's a big trial going on now, which is randomizing these patients to a proximal intervention or deferred secondary interventions.
Ross, can I ask, sorry, Domenico, you wanted to say?
Ross, I agree what you're saying, but there is a big argument in saying instead to stent this patient, you do only an angioplasty, and then you can treat with a carotid endarterectomy the significant lesion. So you do a simple angioplasty, do the intracerebral thrombectomy, and few neuroradiologists are in favor to do only a simple angioplasty because, again, the risk of bleeding post-thrombectomy because the patient had to be on high dose of dual antiplatelet.
Yeah, this is one of the complicating issues, and we're again, this is a subject that we will be considering in the 2022 guidelines. And fortunately, you know, there will be a randomized trial, but I don't think it's going to provide an answer before we've published the guidelines. But it's an area that when we did the 2017, we had one paragraph and said there was no data. There is now more data, but it's still not quality enough to be able to make a definitive recommendation.
Sorry, yes, Richard?
I think that, Patrick, the advent of mechanical thrombectomy has re-energized carotid stenting in the eyes of neuroradiologists. They were loath to get involved in this, really, in many countries, but now they're excited about it as a potential therapeutic option. And I guess the hawks, as Ross calls them, would say that they've done the difficult bit. They've accessed the carotid arch, they've crossed the culprit lesion or the potentially culprit lesion with a wire, and a simple balloon angioplasty, as Domenico says, it would seem to me not an unreasonable thing to consider. I do agree with Domenico that once you put a stent in, you're then mandating quite aggressive dual antiplatelet therapy and possibly increasing the risk of hemorrhagic transformation of the ischemic area.
So Ross, what part does CAS play in the sort of Leicester Group's practice? Because I remember when CAS came out, it was fueled by a lot of enthusiasm and some really superb technicians, because I remember watching Patrice Bergeron do a couple of cases live, and he was all finished in 1 hour and 10 minutes, 2 cases, direct puncture into the common carotid artery, and he was a real master with CAS. But the facts are that CAS has gone into the boxing ring with carotid endarterectomy on several occasions, and it's come out all bruised and battered. And I don't know where CAS, what role it plays in your Leicester sort of group practice.
It has a small role. I mean, I think because you'll be aware, Leicester's been one of the major world drivers in trying to treat people as quickly as possible. And when we last did our audit, I think it was 50% of our symptomatic patients were treated within 7 days and about 80% within 14. And to be fair to our vascular radiologists, who are really good, very accomplished, they were wary about being asked to do these interventions within 48, 72 hours of symptom onset, and the knowledge that the surgeons were getting death and stroke rates of about 3%. We do ask them to do, there are certain people in whom for overall general fitness that they can't undergo a carotid endarterectomy, or it's too challenging to do it. And this is why I use that, hey doc, what's my risk of intervening? Because then you can look very critically at what features the patient has. Because let's say, for example, you've got a 54-year-old lady who had an episode of amaurosis fugax 5 months ago. I would treat her medically, because she's a totally different ballgame of risk compared to an 80-year-old man who's had a hemispheric stroke 2 days beforehand, preceded by a TIA. See what I mean? I encourage my young colleagues to start developing that mental game of tennis of building up a pattern of thinking the way through the patients about what their relative risks are. It's not always surgery versus stenting. It can also be medical therapy as well.
And yes, Richard.
Also, it's an old chestnut, but I'll pose it just for the benefit of discussion and the audience. The timing, the rush to expedited carotid intervention is based on data from NASIS and ECST, which were very old trials, where the medical therapy for these patients was really Stone Age. Aspirin was the only antiplatelet therapy used, and statins were not used at all, and most were enthusiastic smokers. Because of that, I imagine the absolute risk of recurrent strokes is higher in these older trials than it is now with modern, really good aggressive medical therapy in the acute stroke period. So convince me that the marginal gains you get from rushing to carotid endarterectomy is justified.
Right. Well, it's not just the old trials. And that slide I showed you of the natural history studies in the first 7 to 14 days, those have all been published in the last 10 years. And those two pictures of the disrupted plaques with all the fresh thrombus, these were in patients who were on dual antiplatelet therapy. We had them on dual antiplatelet therapy and got them into theatre. And, you know, you can each look at those. If that was in my neck, I really, really wouldn't want to wait too long before I had that plaque taken out. And the reality is that certainly in my own personal practice and looking at the NVR data, we can do endarterectomies within 3 to 5 days with admirably low complication rates. So I don't think, I mean, I think the evidence still supports expedited intervention. I don't think it supports emergency procedures. So for example, we don't do any emergency carotids over the weekends. We'll have them on dual antiplatelet therapy and do them on the Monday if that becomes the case. But certainly if it was, you know, if it was N=1 in my neck, I'm not sure I'd want to be walking around on dual antiplatelet therapy with either of those two carotid plaques that I showed you.
All right. Okay. And do you think, you know, to all you three, TCAR has made a lot of waves recently. And do you think we're running away without the evidence? Or do you think it's ready for prime time? Do you think there's equipoise now for another big trial of surgery versus TCAR?
The evidence for TCAR is non-randomized. It's large registries of surgery versus large registries of TCAR. The SVS VQI registry data is quite impressive. But that's not the same as randomized trials. So I think what is required before TCAR is considered equal to or superior to carotid endarterectomy is a randomized trial in symptomatic, and we'll get on to asymptomatic patients as well. But if both are equivalent, I imagine patients would vote with their feet and choose a minimally invasive approach rather than surgery, I imagine.
Ross, you wanted to add?
This whole question comes back down to the performance of TCAR in these first 7 to 14 days. The registries allow you to have symptoms within 6 months. And I'd just like to quote you a remodeling of the NASCET and ECST data. If you operated within 14 days with a 10% death and stroke rate, which just about everybody listening to this webinar would say those are appalling results, you will still prevent more strokes at 5 years than if you waited 4 weeks and then operated with a 0% risk. So you cannot just have this, well, we've had symptoms within 6 months and that's symptomatic, and we'll compare them with the more recent data in surgery where we're treating people very quickly. We must have the data stratified for delays to symptoms. That is the beginning of real recognition for TCAR. If TCAR can be shown to perform comparably to surgery within the first 7 to 14 days, that will be a game changer.
Okay. Ross, perhaps we should carry on with your talk and we'll pick up the questions as we go along.
Okay, so I mentioned to you about the effects of rapid treatment as being important and favouring surgery. This is the effect. Remember, our patient was 79. I put that down as a risk factor for stenting. This is the meta-analyzed data of symptomatic patients in the 4 largest randomized trials stratified for the age of the patient. And if we look at CAS, comparing with the less than 60-year-old patients, excuse me, as you get older, the risk of death and stroke increases significantly. Interestingly, that is not apparent at all in surgical patients. And this was also found in the NASCET trial back in the 80s and 90s. And when you compare CAS versus CEA, what you need to look at the 95% confidence intervals on the right. Once both of them are above 1, that means that stenting has a significantly higher death and stroke rate, which means that over the age of 70, stented patients have significantly higher death and stroke rates compared to surgery. The next thing is that CREST also showed that if you have long lesions, and in this case, they put 12.9 millimeters as the less, that was associated with significantly higher death and stroke rates in stenting versus surgery with the same type of lesions, as was what they described as sequential lesions. You can see here, you've got, in both these examples, you've got a stenosis at the origin of the internal, then another one higher up. In that situation, CAS was associated with significantly higher rates of death and stroke, probably because they had to use more than one stent, which was found to be a very high predictor of poor outcomes in the randomized trials. And in this huge meta-analysis, I think there were over 75,000 patients in this one, this is where it shows that a contralateral occlusion is associated with significantly poorer outcomes after surgery than with carotid stenting. So here's our man, the one that we started off with at the beginning of this talk. The pro-CEA features are age greater than 70, symptoms less than 7 days, and stenosis longer than 13 millimeters. And the features supporting stenting is the presence of contralateral occlusion, and of course the fact that you're going to have a low CNI risk. I think you wanted to come in at this point, Patrick.
So, you know, I just wanted to ask the panelists, you know, how many of them would be doing an operation on this, or perhaps referring to a skilled colleague for a stent? I think a unanimous sort of. Domenico, quick answer.
Unanimous carotid endarterectomy. Yeah. I see the argument of Ross about the contralateral occlusion. In reality, in my experience from the patient when I performed the carotid endarterectomy under local, patient with contralateral occlusion require less shunting than the one with the bilateral severe stenosis. So, yeah, I can see on the data there is an excessive risk. My personal experience under local anesthetic, contralateral occlusion not been a major deterrent to stop the carotid endarterectomy.
Richard?
Patrick, just to chip in, but the finding of age impacting really badly on performance of carotid artery stenting is an interesting one. I'd be interested in the panel's views as to what's driving that. One hypothesis is that the older one gets, the more tortuous one's arteries are. I mean, the tortuosity is quite a bad morphological risk factor for outcomes following stenting. And also, tortuosity pushes people to use open cell stents, which are more conformable to the tortuous arteries, with an increased risk of plaque extrusion and embolization. I don't know whether Ross or Domenico have got any other insights as to why old people should do less well with stenting than young people.
Well, nobody really knows. There's been a variety of hypotheses, some of which you've mentioned, also increased calcification. Ironically, age over 80 or age over 75 in Roadster 2 is classed as a high risk for CEA criterion for being stented, which is perverse beyond all belief. I think this is something we still have to determine.
Can I ask whether COVID-19 has sort of affected how you approach the carotid endarterectomy? Because I've seen a colleague of mine, Rubina Aslam, do a very elegant local anesthetic eversion carotid endarterectomy. It really took no time at all. And, you know, I'm not sure whether worldwide we're seeing more patients being treated perhaps with sort of stents or maybe a local anesthetic technique. Has it changed the way you practice at all in Leicester, Ross?
At the initial outbreak of COVID, we were similar to about 40% of vascular units that were in a gigantic audit run by Thanos Saratsis, which showed that they were basically only treating patients with crescendo symptoms, and they were being aggressively treated with dual antiplatelet therapy. And interestingly, we had one patient, there were only relatively small numbers of patients. We had one who stroked on the day they were seen in the TIA clinic, so we couldn't have changed anything anyway. But the risks of stroke were not perhaps as high as we thought they were. But now we're back to operating as normal.
Yeah. Okay. Right, let's carry on.
Okay, so in this particular patient, I would have opted for surgery probably being the best option. So now let us take exactly the same man, but instead of him having multiple TIAs, he's now asymptomatic. So he's got a 70% stenosis, contralateral occlusion, 3 centimeter long lesion, and a small left MCA territory infarct. I think, Patrick, you were going to ask the two panelists whether they would consider this patient for surgery.
Yay or nay? Very quickly, Richard, Domenico. This patient.
Yes, for me, because this is how he was the day before his stroke. So I'd have done surgery to prevent him having the stroke that Ross spoke about just at the start of the talk.
I agree with Richard. Definitely carotid endarterectomy.
No faith in best medical therapy at all. No, let's carry on.
I remember a beautiful paper that Ross published in 2004, where he said that it was challenging the best medical therapy that potentially might render the carotid endarterectomy obsolete. And his conclusion, if I remember well, Ross, you say carotid endarterectomy will offer you an immediate prevention, while the world is imperfect and people, they stop taking aspirin, they stop taking statin, and they stop taking the blood pressure medication. Is it the word perfect now, Ross? Or
you're not very European. you are very European. You will.
I'll tell you what I think towards the end of this section. I'll keep stumm for now. Okay, so in this patient, we've still got to get the lifestyle sorted out. This is the evidence for best medical therapy in asymptomatic patients, and it's poor. There's never been a randomized trial about aspirin, and there's observational studies have actually been quite conflicting. And so when we did the guidelines, we advised you should be on aspirin, low-dose aspirin, in order to prevent late myocardial infarction, which is the principal cause of death in patients with asymptomatic carotid disease. Similarly with statins, there's no randomized trial, and they're used to prevent late stroke and particularly MI. Meta-analyses show reduced perioperative death after surgery and perioperative death and stroke after stenting, and you should not stop statins during the perioperative period, and the same criteria for blood pressure. This is the data that Richard and Domenico have basically used to justify their action in saying they would intervene. On the left-hand side is the stroke risk for surgery, and then the stroke risk for medical therapy. And you can see the 5-year data for ACAS, the 5-year data for ACST, and then the 10-year. And the magnitude of risk is a whole level less than with our symptomatic patients. And on the right-hand side, looking at the number of strokes prevented per 1,000 operations, you can see that about 50 to 60 strokes are prevented per 1,000 operations at 5 years and 46 at 10 years. So whether you like it or not, what that means is that 95% were ultimately unnecessary. And I don't think there's any anti-cancer drug or anything like that that would be licensed if it didn't work in 95% of people. But that's a debate for the future. This again shows you the meta-analysis of the 3 randomized trials who randomized more than 500 patients comparing stenting with surgery. And there's a similar pattern in that 30-day stroke is significantly higher after stenting. The death and stroke this time is non-significant, but if you look at the confidence interval at the bottom of 0.98, the lower one, that's almost at 1. So that it's trending the same way as the symptomatic patients, that stenting is still associated with a slightly higher risk of stroke in the asymptomatic patients as well. Now, the American Heart, this is their guidance that they published in 2014. And they recommended that for the patient like the one I described to you, surgery is indicated in highly selected patients, and that stenting might be considered in highly selected patients. Well, that's brilliant. If they then told you what highly selected mean, because they never did, so that you had to guess yourself. And because of the medical legal situation, particularly in North America, most people just treated everybody. Now, unless you've been on a different planet in the last 5 to 10 years, this is probably one of the most controversial debates, the management of the asymptomatic patient. And if you look at this slide here, this shows you the proportion of carotid intervention workload that is asymptomatic for a whole host of countries. Now, if you look at them, it ranges from 0% in Denmark. Now, it says that it's 70% being the highest in Italy. The USA number is definitely underestimated. It's up between 80 and 90%. And on the left side, you'll see Australia with about 38%. Actually, the Australian Stroke Organisation have now published a recommendation saying that you should not perform any intervention in asymptomatic patients. So over to you, Patrick, for the interpretation of this.
Ross, I mean, that's a very interesting slide. And we were talking to a very good friend of mine who works in Milan, and he said that his carotid workload was 90% asymptomatic. And I just want to sort of ask Richard and Domenico, why do you think that's the case? I mean, Ross has showed us an interesting slide. We've got the evidence before us. Why do you think the UK is so conservative compared to some of these countries that's shown?
One thing we've learned from COVID is the myth of British exceptionalism. And I think probably rates of intervention in the United States for asymptomatic patients is too high. Rates of intervention in the UK probably too low, and the sweet spot is possibly somewhere mid-Atlantic. We have a socialist or socialised medical service in the United Kingdom, where actually there are strong incentives not to intervene when you look at it at a national level. In contrast, in the United States, you've got strong monetary incentives to intervene. But not intervening isn't always the right thing to do. For example, we were slow to the party for mechanical thrombectomy for stroke, and we know that works, but the British were slow adopters for that. Similarly for EVAR as well. It's a nice slide, but I'm not sure that saving money and not intervening is necessarily the right thing to do. There are sins of commission and sins of omission, and it depends what side of the fence you sit on.
Mm-hmm. Domenico, what proportion of your patients? I mean, you've got a large volume and quite impressive outcomes on the end.
My figures are
symptomatic.
Since 2008 until now, I've done probably 560 carotid, and 86% are symptomatic.
Yeah.
So yeah. I'm quite selective to be high stenosis, high degree of stenosis, but I'm very, very peculiar in looking at the morphology of the plaque. So morphology of the plaque for me is a major incentive if it's dishomogeneous with high stenosis to do a carotid endarterectomy and asymptomatic.
Yeah. So Ross, what about the proportion of asymptomatics to symptomatic patients in your own practice? And do you aggressively chase down the high-risk asymptomatic patient?
Okay. Well, in our practice in Leicester, it's about 8 to 10% is asymptomatic. And I'll come back. I'll answer your second question in about 4 slides' time.
Sure. Okay. Let's carry on.
Okay. Now, there are several factors that have stirred the debate, and that is that with time, there appears to be a reduction in the risk of stroke in patients with carotid stenosis that are treated medically. And there's been a lot of criticism of this data, that it's not randomized, that they're contaminating with a lot of moderate stenosis. But this slide is very carefully made. The blue symbols are any stroke, the red symbols are ipsilateral stroke, and then depending on the shape, depends on whether it's 50 to 99, 60 to 99, or 70 to 99. And you can see that whichever way you look at it, there appears to be a downward trend in the risk of stroke in the modern era compared to the older era. And if you look also in there, you'll see the ACAS 5-year results, and then the subsequent first 5-year results of ACST, and then the second 5-year results. You can see that they're fitting in with the trend. So there is a question. I'm not saying that this is the definitive answer, but there is a question about the role of modern medical therapy and the risk in current asymptomatic patients. And this slide summarizes the debate, the controversy. If you are a person who really believes in intervening in large numbers, all your arguments are in the blue box. And if you're a skeptic about mass treatment of asymptomatics, your arguments are in the red box. And they basically come down to this, that the American heart guidelines are based on level 1 evidence, but they're very historical now. The risks of stenting and surgery are lower, therefore they'll be getting even better results in the modern era. Well, the reality is that I showed you the slide that showed that 95% of interventions were ultimately unnecessary. Well, if you had a 0% risk, 93% would be ultimately unnecessary. So it's not going to make a big difference. It is true that it's the only way to prevent the strokes in those who do not have a warning TIA, which is what Richard mentioned just earlier. But the reality is, for the public health doctor, that if you offered endarterectomy or stenting to every asymptomatic patient, then 96% of all the strokes destined to occur in your community will still happen, because the vast majority are nothing to do with asymptomatic carotid disease. There's arguments about the validity of modern medical therapy, but hopefully CREST-2 will answer that for us. And while the American Heart said you should only be operating on highly selected patients, they didn't clarify what they meant. And the people who are opposed to mass interventions say there's no validated method for identifying high-risk patients. Now, the European Society of Vascular Surgery collaborated with the European Society of Cardiology to come up with consensus guidelines on PAD, and one of the chapters was on carotid disease, and I can tell you it was a challenge and a half to get 85 authors, reviewers to agree on the optimal management of asymptomatic carotid disease across all the specialties and countries. And what we did was we recognized that some people would definitely benefit from endarterectomy or stenting, and others didn't. And we came up with this algorithm, which basically said you should have a minimal life expectancy of 5 years, favorable anatomy, and then more than one feature that suggested a higher risk of stroke on medical therapy. And we put these endarterectomy at 2A and stenting at 2B, largely based on the fact that stenting was associated with a slightly higher 30-day death and stroke risk. And the clinical or imaging features that may be associated with an increased risk of stroke on best medical therapy were not taken from single center studies. They came from randomized trials, multi-center studies, or meta-analyses. And we identified these 4 clinical, CT or MI, ultrasound imaging, and MRA plaque analysis. And I'm going to show you some of the data that comes from this. So this is stenosis progression. If you have progression, the annual risk of stroke is 2%. If it's unchanged, it's 1%. And if it regresses, it's 0%. If you look at silent infarction on CT MRA, as our patient had, that increases the annual risk of stroke to 4% versus 1%. If you've got plaque echolucency, just an eyeball test going that plaque looks black or that plaque looks white, then if you've got an echolucent plaque, you've got a 4% annual risk of stroke versus 1.6 echogenic. That's on a meta-analysis. If you look at the increasing plaque area, this is on computerized plaque analysis, then the bigger the plaque, the higher the annual rate of ipsilateral stroke. And the same with the size of the juxtaluminal black area. This is the area of echolucency immediately below the luminal surface. And this is basically the lipid core. And the bigger this is, the higher the rate of ipsilateral stroke. And it reaches 5% per year if the plaque area is greater than 10 millimeters squared. If you've got intraplaque hemorrhage, yes or no, that increases the risk of late stroke. As does the presence of impaired cerebral vascular reserve. And even, and another really important one is the presence of spontaneous embolization on transcranial Doppler. And if you stratify that for, have you had 1 or more emboli in an hour, yes versus no, that increases the risk of stroke by a factor of 7. And something as simple as a contralateral TIA or stroke, and this has been not just in the Nicolaides, this was ACST as well, that was associated with an increased risk of stroke of 3% versus 1% if you didn't. I think you wanted to come in with a few questions on this.
Yes. So, Ross, I mean, thanks for those slides. It seems that we've made some tremendous progress since Andrew Nicolaides' grayscale median sort of way of classifying stable or unstable carotid plaques. In your practice, Ross, can you tell us, I mean, do you use all of those criteria, try and implement all that criteria that you've shown us, or, what are your top three, perhaps top few features that will alert you to saying this is a high-risk patient, perhaps, they deserve a conversation about asymptomatic carotid surgery?
Right. It comes up in 2 slides' time, but I'll tell you what I do. So if I had this particular patient, I already know he's got a small area of ipsilateral infarction. I would do an hour of transcranial Doppler monitoring a week apart, and I would do computerized plaque analysis, and I would base my advice to the patient on intervention based on the findings of that, and I would keep him in surveillance if I didn't operate immediately on him. So yes, the European guidelines have made my life a bit easier, because now I'm trying to be a bit more objective. I would like to have better evidence, and I would like to be able to have a scoring system that's better than this, but this is a start. You can't advise highly selected patients should be treated if you don't say who they are. This is just a start.
Yeah. Richard, you wanted to chip in?
I think the feature I find most useful is the history of prior stroke or evidence of silent brain infarction and cross-sectional imaging, because most of these patients will have had a CT scan of their brain. Because in the United Kingdom, most patients don't just rock up for a carotid duplex scan for no reason. Normally something has happened that has pushed them towards the vascular laboratory. And that's sometimes a contralateral event, sometimes a posterior circulation event. But these aren't entirely asymptomatic patients, in contrast to the United States, where screening for carotid disease is, whilst not recommended by central government or insurers, it's widely practiced. So in the United States, you do get entirely healthy people with a truly incidental carotid stenosis. In the United Kingdom, many of our patients in the trials, it was as many as 1/3 have had prior brain infarction. And I guess it's previous performance does predict future performance. And if you've shown you're an embolizer from carotid disease, you're likely to re-embolize.
Domenico, in our part of Surrey and Hampshire, there are lots of patients who pay to have their carotids screened. And this causes quite a bit of consternation with them and their GPs, and they eventually get referred to us. I'm going to ask all three, Ross and both panelists, is there a role for screening to detect asymptomatic carotid artery stenosis? Domenico, perhaps you go first.
Well, if you start screening patients with peripheral vascular disease, you will find a huge amount of carotid artery stenosis. But to be honest, I don't believe it's the right way to do it. Unless you find a really subgroup of patients that will be the ideal to be treated. But as Ross said, we don't know who they are. And when I see an asymptomatic stenosis because not being screened for any other vascular problem, but just because the neurologist send it to you because with a soft sign, then it's the only way that we see this patient treated.
Yeah.
Patrick, I think carotid screening does fulfill many of the Wilson-Younger criteria for a successful screening program. You've got an acceptable risk-free test, that's a carotid duplex scan. You've got a condition which, if identified early, the natural history can be changed, not necessarily just by surgery or stenting, but also medical therapy. And nobody would argue that knowledge about a carotid artery stenosis cannot but help medical therapy for these patients. Statins, antiplatelet therapy will reduce their long-term risks of heart attacks and strokes. But it gets a bit thorny when it's viewed as a way of mendacious vascular surgeons or carotid stentors identifying patients to enrich themselves, not necessarily the patient's lives. But the other thing is the overall prevalence of carotid artery stenosis in the general population is spectacularly low. And I think you'd have to scan loads of patients to identify large numbers of carotid stenoses. But we're looking in Oxford at a targeted screening program using sort of simple patient criteria, age, comorbidities, hypertension, high cholesterol, diabetes, And by enriching your screening population, you might make the numbers work, looking at medical therapy to reduce long-term stroke risk, and then selected intervention with all the caveats that Ross has mentioned about that phrase.
Richard, but are you not going to treat this patient anyway with the best medical therapy? If you are...
Yeah. So Dominica, we looked at that in a population of 3 million US people who rocked up for commercial screening, and the diagnosis of carotid stenosis did impact positively the medical therapy in over half of these patients. So a lot of people would not have qualified for good medical therapy prior to the diagnosis of carotid artery stenosis. So I think it does add something to the medical to their medical therapy management.
Ross, your last words for this debate, mini debate that we're having about screening?
I'm not a supporter of routine screening. I think for a variety of reasons, the yield is very low, and unless you have a model for identifying a group who has a high prevalence of carotid stenosis, an enormous amount of money will be spent on trying to prevent a tiny number of strokes, and there are way more important things we need to do. I would caveat that by saying that if I had enough confidence in surgeons and interventionists that the finding of a vast number of significant stenosis did not trigger a plague of carotid interventions, if I could be convinced that was not the case and that we would really target best medical therapy in order to prevent late MI, and I think that you will prevent far more deaths in the long run by preventing MI and cardiac-related pathologies than you will in preventing stroke. So I'm very skeptical about it, maybe cynical would be a better word about it. And even with targeted screening, one of the problems is, I mean, Alan Davies' group did a model of this where they used the SVS selective criteria, and they worked out that they would, if you screened UK claudicants at the age of 60 with a one-off duplex scan, it would cost 17 million, and you'd only prevent 230 strokes a year, which is 0.2% of the overall UK stroke workload, and it would cost £76,000 per stroke prevented. This is nonsense. So, you know, I'm not convinced about screening. I can see the logical attractions of it, but I think there are too many conflicts of interest.
Yeah, I agree. Money better spent on a good crate of wine, I think, when they come to me and ask me. Anyway, Ross, let's continue your talk.
Okay. Now, the one thing that neither of my colleagues mentioned was that our patient is over 75, and ACST showed no evidence of any benefit for intervening in patients over the age of 75. And this is the 5-year risks of stroke for the immediates or the deferred. But if you notice, they've not included the 30-day risk of stroke, so that there was a non-significant benefit for immediate surgery. But by the time you now add in the death and stroke rate, which was a commendable 3.7%, there's absolutely no benefit. But my colleagues, one of whom is the ACST PI, seems to have forgotten what his trial showed 10 or 15 years ago. There's also no evidence that a contralateral occlusion increases the risk of stroke. Now, this is intuitively ridiculous. I've just shown you that it was the single biggest predictor of benefit in the symptomatic patient, but in the 2 large randomized trials with very careful scrutiny, there was no evidence whatsoever that a contralateral occlusion increased the risk of stroke. So in this patient, you asked me earlier on, Patrick, what I would do. The pro-intervention is the silent infarct on CT. The pro-medical therapy thing is that he's over 75. And in my practice, I said I would do transcranial Doppler and computerized plaque analysis. And if they had an echolucent plaque or emboli, I would be much more minded to intervene, even if he was over 75. But in the absence of that, I think I would have treated this patient medically.
Right. Okay. So we're going to pause to take some questions, but I'm going to ask, sorry, Richard, you wanted to...
I'm rising to Ross's provocation. I guess ACST1 was done 15 years ago, and things have moved on, Ross. We're all getting older. And 80 is probably the new 75, because it doesn't matter so much how far you are from the date of your birth. It's how close you are to the date of your death that matters when you're considering the advantages and disadvantages of carotid intervention. and we're all living longer. So I think in my practice, I've knocked that age 75 up a little bit to closer to 80. Because I think really what you need to do, you need to look at your patient and say, does this person have a reasonable prospect of 5+ years of good quality life? If the answer to that is yes, probably, I think carotid intervention is still a reasonable thing. If it's probably not, well then no, because you need to live for at least 4 years before you buy back the perioperative hazard of carotid intervention. So I think ACST1 75 is probably 80 now. So that's what my age threshold now is.
Yeah. Can I ask Domenico a question? One of the things that about the ACST2 trial is that in Surrey, I think Alison Halliday did come twice to speak to us about the merits of randomizing our asymptomatic patients into this trial. And one of the criticisms, whether fair or unfair, of the ACAS and ACST2-1 trials is that these patients weren't properly given best medical therapy, and therefore the true question of whether BMT is better than intervention has not been properly answered, and we're still waiting for that. Your thoughts, Domenico, about that?
Well, as I say, I'm a carotid endarterectomy believer, and I completely agree with Richard said. So probably age is not discriminant anymore. The previous 75 are now the 80 years old patient. Best medical therapy is fantastic. We got a lot of different tablets in our armamentarium, but the point is the patient needs to take it. They need to take it for a long period of time in order to prove their long-term benefit and the prevention. And I'm afraid, I don't believe that the population is keen to keep taking this best medical therapy for a long term. As we know, I mean, the statin has caused a lot of issue among the general population. They cause a lot of side effects, but do I really need to take this? And is the problem we are facing in our practice every day, and keep reminding the patient to stick on the best medical treatment. And probably what Richard said just before, I mean, doing this study and screening the patient will motivate the patient better in remaining on the best medical therapy.
Right. And Ross, your thoughts on, has it been conclusively answered, BMT versus intervention in the asymptomatic patient?
No, it hasn't, because these are observational studies for the most part, but we did have the declining stroke rates in ACST and ACAS over the 20-odd year period of publication. Listen, nothing's going to change until we see the results of the CREST trial.
Yeah.
When they did Sampras, all the people assumed that intracranial stenting would be better than medical therapy in symptomatic intracranial stenosis. The answer was it wasn't, and people were astounded at how good the modern medical therapy was working. This debate, it's a red rag to a bull to some people on either side, and what we need to do is to hope to heaven that CREST-2 can reach its numbers and be able to give us an idea of what modern medical therapy is doing. If it can't maintain a low stroke rate, then that is a very important finding, and the numbers of stents and surgeries will go up. And I think that's the best way to leave this debate, because you're not going to find an answer at present. My viewpoint is try and identify high risk for stroke features and target your interventions in them.
All right. So in the interest of time, Ross, you've got a lovely presentation, the last bit of the presentation on the technical aspects of carotid surgery. So let's carry on, and lots of questions coming that are relevant to the last bit of the talk. Okay. This final section, there's not too many slides, is how should endarterectomy be performed? And what I'm going to quote you is kind of the answers that you would give in your exams for when people say, what's the evidence for a different technique or whatever, but also in the way that you practice as well. So on this whistle-stop tour,
Local versus general? Well, there's no randomized trial evidence that performing endarterectomy under local anesthesia reduces perioperative stroke compared to general anesthesia, full stop. There are large numbers of observational studies which show a benefit for local anesthetic, but these are uncontrolled and subject to bias. The randomized trials, and there have been quite a few now, show no difference. Retrojugular versus antegrade exposure. There's been a meta-analysis here which showed that you can do whichever one you want. They both get equal outcomes, but the one caveat is that if you have a patient with a contralateral recurrent laryngeal nerve palsy, you should not do a retrojugular exposure because they are more likely to get a recurrent laryngeal nerve injury, no matter even if it's temporary, in patients with a retrojugular approach, and you could end up with a patient in very severe trouble who can't breathe when you extubate them. Carotid sinus nerve blockade, absolutely no evidence that it reduces the prevalence of perioperative hypertension, and arrhythmias, and this was a meta-analysis published in the European Journal. One of the pieces of information that I found most useful in my practice was John Kakisis's meta-analysis on the role of protamine reversal of heparin. Previously, I was very, very wary about giving protamine, but heparin reversal using protamine reduces the prevalence of neck hematomas without increasing the risk of perioperative stroke. And I am now more happy, more comfortable about giving protamine. I don't give it routinely, but if I've got a patient who's still oozing at 15 minutes through the patch, I'll quite often do a TEG to confirm that it's the heparin effect, and I will then give them protamine. Shunting, there is no evidence whatsoever to guide practice, so you tend to be a prisoner of your own prejudice, and that is what you were trained to use by one of your most influential bosses. I'm afraid you will not find any randomized trial evidence to help you. In terms of patching, routine patching is preferable to routine primary closure with reduced rates of perioperative stroke, postoperative thrombosis, and late re-stenosis, and there is no evidence that patch type influences outcome. Eversion endarterectomy, there is no difference in early or late outcomes when you compare eversion endarterectomy with patched endarterectomy. However, if you compare eversion endarterectomy with primary closure, eversion endarterectomy gives you better results and particularly lower rates of re-stenosis. I think you wanted to come in with some questions there, Patrick.
Yeah, so I just wanted to ask our panelists, Richard and Domenico, maybe Domenico first, what is your standard approach? What would you consider your sort of go-to technique for endarterectomy?
Shall I go first? Or?
Yeah, Domenico, yeah.
I think patch is my first line surgical technique, followed by eversion. Very rarely primarily, unless the carotid is ectatic. And I use bypass for bailout or...
Shunt, you mean, yeah.
Bypass, sorry?
Or bypass for a bailout.
Bypass, carotid bypass for very specific circumstances like bailout of the failed carotid or failed endarterectomy, or in carotid post-stenotic radiation induce injury, that's it.
Or awake or asleep for your patients?
Well, at present, I do the majority of my patients under GA. I used to be quite a strong supporter of local anesthetic. Now I leave the patient to decide which anesthetic he wants. So if the patient is happy with local, I will do under local. If the patient is not happy, we'll do under general anesthetic. Doesn't make a difference.
COVID hasn't changed your outlook on GAs or local approaches.
Sorry, say again?
COVID-19 hasn't changed your outlook on a GA or local approach.
Well, it's a very good question. Definitely I was more keen on local, but the amount of surgery we did since the lockdown was really minimal. And since March, I've done probably 12 carotids in total. So,
and Richard, your how you do your?
If suitable and a willing patient, local with eversion. And the requirement for shunt really, really low in those circumstances. If GA is necessary or patient wishes, it's a classical approach, so longitudinal arteriotomy and patch and universal shunting.
I see a lot of trainees who've gone through Oxford are well trained in doing the eversion endarterectomy. I mean, are there any circumstances in which you wouldn't do a eversion endarterectomy? You think perhaps that's the wrong choice?
No, it's almost the opposite. There are some circumstances where I think it's a really useful thing to do with the elongated tortuous carotid, which you want to shorten. I think an eversion is a really nice approach there. The alternative is to sort of placate the posterior wall of the carotid artery, and Ross has given a nice talk about that previously. But I can't think of a circumstance where an eversion is not a good approach. But as I say, I like to do it under local anaesthetic where you know you're not going to need a shunt.
And Ross, what's your main sort of endarterectomy?
I'm general anaesthetic, antegrade exposure, routine shunt, routine patch, no carotid sinus nerve blockade, and I've never done an eversion endarterectomy, but there's no problem in people doing that because it's just as good as a patch and vice versa.
And despite your slide saying there's no evidence for a shunt, it is a comfort blanket.
Well, about 80 to 90% of all the carotids done in our unit is done by the trainee, and I can take as long as I like. I've got transcranial Doppler monitoring, I've got completion assessments, I know what's going on all the time, so I can take as long as I need to help my trainees get through the case. I was also taught by Peter Bell, and I just said to you, you're the prisoner of your own prejudices.
And Ross, the value of intra-operative monitoring during the endarterectomy, TCDs and oximeters, and I mean, what are your thoughts on that?
Well, this is again another one that tends to be a red rag to a bull. We published our 21-year series of using targeted monitoring and quality control. We use intraoperative transcranial Doppler, we use completion angioscopy, and we have aggressive blood pressure control. I think that's the trio that has made such a difference in our practice.
Sure.
The intraoperative transcranial Doppler, I just want to mention here, intraoperative transcranial Doppler tells you whether your patient is embolizing while you're dissecting the carotid. It tells you whether your shunt is working, because 3% are abutted on a coil or a kink higher up. It tells you whether the flows are greater than 15. If they are, you won't get a hemodynamic stroke. And then in the incredibly rare patient, it will tell you if your patient is thrombosing their carotid as you're closing the neck. That's all the function it has. So actually, even if you do it under local, most of those requirements are still there for you.
Sure. Okay, Ross, let's finish your talk and we'll answer some of the tranche of questions.
All right. Well, let's try not to get controversial. Oh, come on, yeah, we will. Should surgery or stent patients be kept in surveillance? This is one of the most controversial subjects after asymptomatic carotid disease, and the European guidelines radically differ from the American. And they were largely informed by this meta-analysis and systematic review that our group did. And what we did was we took randomized control data only, not observational studies. And we looked at the prevalence of re-stenosis and the data on re-stenosis before stroke onset. You have to look at the stenosis severity before the stroke onset. And we chose randomized trials because they're prospective, greater scientific rigor, selection bias is reduced, and there's independent observers. And what we showed was that if you have, excuse me, any endarterectomy, the re-stenosis rate at 4 years in 11 randomized trials was 5.8%. And in CAS at 5 years, it was 10%. So that stenting was associated with significantly higher rates of re-stenosis. It was slightly lower with patched endarterectomy. But the guidelines tend to recommend that it's a benign condition. This is the 14 Society guidelines, and it does not need any intervention unless it becomes pre-occlusive severity or they have symptoms. Well, in this meta-analysis done with Gert de Borst's group, 2/3 of patients undergoing redo endarterectomy or CAS for re-stenosis were asymptomatic. So there's clearly a problem here, either with confidence or other issues. And this meta-analysis we did, here's 4 randomized trials, nearly 2,000 stented patients, at just over 4 years, the risk of stroke, if you had a restenosis greater than 70%, was 0.8% versus 2.0% if the restenosis was less than 70%. And that's quite astonishingly low complication rates for stented patients. With surgery, at 3 years, nearly 3,000 patients in 7 randomized trials, the risk of stroke with a restenosis greater than 70% was significantly higher than with no significant restenosis, but the differences in terms of absolute differences are not that particularly great. And the reality is that if you take 6% will develop a 70 to 99% restenosis at 4 years, you'll have to screen 1,700 patients in order to identify 100 with a recurrent 70 to 99% restenosis. And if you intervene in all of them, you might prevent 5 strokes, but you'll also cause 3 because of the CARS or the redo surgery. And even if you do all that, 85% of all the late ipsilateral strokes that are destined to occur will still happen because they're destined to occur in patients with restenoses less than 70%. And so the European guidelines advise re-intervening if you have a symptomatic restenosis. I have absolutely no problem with that. You may consider re-intervening in endarterectomy patients with an asymptomatic 70 to 99% restenosis, but we urged careful MDT review, and we couldn't find any evidence that CAS patients who develop a restenosis should require a re-intervention. We did, however, advise that if during your surgery under local you got symptoms under local anesthetic or with balloon inflation with proximal protection devices with stenting, then these patients will not tolerate progression to occlusion and they should be kept in a surveillance program and intervened on. And similarly, those who had EEG or SEP changes or very low velocities, in our situation less than 15, we would advise serial surveillance and re-intervening. Now, this is the American surveillance strategy. You get it at 3 months, every 6 months for 2 years, annually till no significant restenosis, and then every 2 years for the patient's lifetime. Now, you can imagine that the European guidelines caused quite a bit of a stir, and this, I don't know if you read all this, but this triggered a series of editorials in the JVS. There were 3 of them, one by Cosmas Paraskevas and Peter Glowicki, one by me, and one by Zirla, who was the lead author for the SVS guidelines. And the argument from Paraskevas and Glowicki was that while the data and the meta-analysis was interesting, North American experience was totally different to European. And they cited the fact that there was a small cohort of patients who developed significant restenoses and symptoms, and these mandated a more aggressive approach. Well, you know, sometimes you need to look very carefully at the literature and the data. So if you do adopt the CREST data, 6 out of 62 people with a significant restenosis, that's just under 10%, which is quite a lot, suffered a late ipsilateral stroke versus 1.2% with no restenosis. However, if you then put all 1,100 into surveillance, you might prevent 6 strokes, that's 0.54%, which means that 99.46% undergo unnecessary surveillance. Not quite so convincing. And it's even less convincing if you take the stent data, because then it's 99.91% are undergoing unnecessary surveillance. So I'm not convinced by this blanket surveying everybody. Certainly not in my practice. We adopt the ESVS criteria, which you'll not be surprised about. But I think sometimes you can't take the evidence that's been thrown at you at face value. You need to look at it in alternate ways in order to make a balanced judgment. Now, in closing, I've given you an awful lot of data this evening, and you'll be able to find all of the data that I've given you in the European Society of Vascular Surgery 2017 Clinical Practice Guidelines, which are now being updated for 2022. Thanks very much.
Thank you, Ross, for what a masterclass. I think that there are lots of questions submitted tonight, and we thank you for all the questions submitted. We've not had a chance to answer all your questions, but the faculty will do our best. I think just one closing topic to sort of end the webinar with, Ross, and as we perhaps didn't touch on it, was the approach to the patient needing cardiac surgery and the asymptomatic carotid stenosis What's your advice, Ross, for us with these patients?
Okay. Well, I used to be an ardent advocate of doing synchronous endarterectomies and CABG. I've got a personal experience of over 135, which is pretty large, and I became an increasing skeptic from about 2000 onwards. Our group did a whole series of meta-analyses, and what I'm convinced of is that carotid stenosis is a marker for bad aortic arch disease, and that it's basically a marker of a poorer outcome, mostly cardiac. And that if you look at the laterality of strokes that happen in patients with asymptomatic carotid stenosis, the vast majority do not match up. About 90 to 95% do not match up to the underlying pattern of carotid disease. So my practice is to consider synchronous procedures in patients who have symptoms, so a symptomatic carotid who you have to do a cardiac procedure on. I don't do any synchronous procedures in patients with a unilateral asymptomatic carotid stenosis, but I will consider them in people with bilateral severe stenosis or a severe stenosis and contralateral occlusion. The reason there is that the death and stroke rate is about 9% in these people. Most of it's cardiac though, and it's less than 1% of the cardiac surgery workload, so it's almost not worth getting your brain all torn to shreds about.
Thank you. Thank you for that. And with that, I'd like to thank our panelists, Richard and Domenico. And of course, Ross, thank you. And I also would like to wish you a very happy clinical retirement, although you are going to be with us because you've reassured us that you're going to be part of the 2022 guidelines.
Indeed. Still doing my academic stuff.
So what are your plans? Tell us, what are your plans for your retirement?
Well, academic seems to be taking up a large part of it right now.
Well, you can't go anywhere, so you know.
And I'm going to start doing a lot of activities that I've never had the time to do before. So I'm looking forward to it. And I've just had my second grandchild, so that takes major priority.
Congratulations. Thank you everyone for your attention and time tonight. We'll see you next week's webinar. Thank you. Good night.